Alafia, I'm Dr. Gloria Lattimore Peace, host and producer of OmniU Presents the H3O Art of Life show. And today I have a program that I have wanted to do for the longest time, and I finally have found the right guest to do this show with. The name of the show is Arrested Development, Addiction, and Mental Health. And I think that you're going to enjoy this show. And I have some very good people here to discuss the subject matter. I have Dr. Adeyemi Fatoki, who is from Great Heights Family Medicine. And I have Dr. Anthony C. Redmond, who is with the New Vision Medical Stabilization Service at the Holy Cross Hospital. And these two people are going to help me to open up the subject. We would not be able to exhaust it here, obviously, because there's just so much more to this than we can cover in an hour's time. But certainly we can begin. And so before I begin, I think my guests would like to get to know you. So I will start with Dr. Fatoki, who is here courtesy of the Reckitt Benckiser Pharmaceuticals. And we'll ask you to tell us something about your background so the viewing audience will get to know you.
Okay. Well, I'm a physician, and I came to the United States in 1982 as a teenager.
From where?
From Nigeria. I went to school at Western Illinois University in Macomb, got my MD from the University of Illinois College of Medicine at Peoria, and I also have a master's degree in public health from the University of Illinois at Chicago. I did my residency training in family practice at Cook County Hospital and worked at Providence Hospital as an attending physician. I also do some consulting work for the state as a physician consultant. And I've worked in the prison systems for, I'll say, about 7-8 years until last year when I retired, or when I resigned from there. I worked as a medical director for a private company that provided health care to prison inmates. And prior to my resignation, I ran the youth centers in the Chicago area for the state. In Chicago, Joliet, Warrenville, St. Charles. And I also ran some county jails in the collar counties. I became interested in addiction because of what I saw at the prison, the way the patients were treated, and also most of the patients were in and out for the same problem. The state in the jails did not address their drug problems, and then they went out, did the same thing, and came back again. And same thing I noticed when I work at the hospitals. The patients coming with a drug problem, we tune them up, send them out, and a few weeks later they're back again under a different physician. So that's really what got my interest in addiction. And then I got certified in treating opioid dependence in the office. And I also have a drug treatment program in my office. It's set up in a private practice setting so that the patients wouldn't feel stigmatized. And I do see them with my regular family practice patients for drug treatment.
Well, that's your opening statement.
Yeah. And it was pretty long.
No, that's a good opening statement because I feel like I know you better as a result. And now Dr. Anthony Redmond.
Yes, I was born in the United States, been in Illinois, Chicago, all of my life, and I decided in 1988 to go into the field of addictions. I started working at Garfield Counseling Center, which is a methadone program on the west side of Chicago. I started my educational pursuit in addictions at Luke City College before it became Harold Washington. I finished Harold Washington, and then I finished my degree at Roosevelt University in counseling. And from there, I completed a master's degree in health science with the concentration in addiction studies at Governor State University. So while I was going to school, I worked at many programs like HRDI, this psych unit in Lamont, Illinois called I can't think of the name right now, but I worked there for about 4 years, and many of the hospitals in Chicago, I spent years working with both populations, those who was abusing various kinds of drugs, as well as those who were presented with various levels of pathology and mental health. I decided to continue on because I just saw that there was much more behind the addiction than the person's behavior using various kinds of drugs. I just knew it was more. That's why I decided to pursue a career in clinical psychology, and I received my doctoral degree at Illinois School of Professional Psychology. I finished last month.
Wonderful.
Thank you.
Congratulations.
Thank you much.
All right. Now, we have met you, and now let's meet the problem head on. Let's meet the problem of addiction and mental health disorders. And in what order should we do it? Maybe we should define addiction so that you know, even though usually everybody thinks that they know what that is. But given the fact that you said two things that interest me, one is that you have a family practice and you are saying there's more to it than the behavior. This means that there must be something about addiction that we need to say. What's the definition of addiction?
Well, it's a complex, chronic medical problem that also a behavioral problem. So it's got both a mental and a medical or clinical component to it. There's also some genetic aspect of it. There have been studies that show that there's a 40% concordance rate of addiction. So meaning that there's a 40% chance that if you have a first-degree relative that has a drug or an addiction problem, that you'll also develop that problem. So it's not just one thing. I know a lot of people believe that people should just stop using whatever they use, but it's a lot more complex than that.
So it's, first of all, it's complex. Secondly, it's genetic.
Yes.
In 40% of the cases.
Yes.
And thirdly, it's more than just behavior.
Yes.
It is also a medical, it's complex medical problems as well.
Yes.
All right. So that gives me, did you want to elaborate?
Yes, I have a more of a simplistic term in looking at addiction, and I see addiction as an inability of a person to stop inappropriate or undesirable behaviors that they commit over and over again, characterized by a loss of control. There's many studies that argue the fact that it's a disease or it's a disorder or it's a maladaptive behavior. But in the final analysis, I think that it's a myriad of things, but wrapped around this inability to start and to stop, irrespective of the major consequences that follows.
But if we're saying it has a genetic component, then what we're saying is that someone is already predisposed to become an addict. So what is the catalyst?
Well, unfortunately, there is no way to tell who has that genetic predisposition. So the way I look at it is it's better never to start, because you don't know if you are one of those persons that has a genetic disposition to it. It's not everyone who tries a drug for the first time who gets hooked on it. It's not everyone who drinks alcohol that can't stop drinking until they get a DUI or it starts to affect their lives in a negative way. There are some people who could have a drink today and not care whether they have another drink in 6 or 7 months. But there are some that once they start, they can't stop. And what's been common to all drugs of abuse is that it releases, they release dopamine in the brain. And dopamine rewards the pleasure center of the brain. And also the different drugs hijack that pleasure center of the brain, making the patient feel, or the individual feel that they need those drugs for them to live. You know, it takes over the pleasures they get from other things. And so that's the medical component of it. It's a chronic disease, just like high blood pressure, diabetes, or hypothyroidism, and that's the way the medical community is starting to look at it.
So we can't start to watch early on if we know that there's an addict in the family. We can't begin to watch for signs. There aren't any telltale signs that would tip us off to this person is inclined or likely to become one who abuses substances or anything that would give us any in a head start and in understanding?
Well, Dr. Johnson, Dr. Vernon Johnson suggested this, that there's 3 stages that a person could possibly progress through to become addicted to a particular drug or alcohol. And the first stage is what we call the early stage. The early stage is characterized by recreational drinking, drinking for social pleasure or drinking to relieve stress. But most people can drink during that period and stop. Well, there's other folks that go to what we call the prodromal period, which is the next phase. And the prodromal period is characterized by the problem is now beginning to manifest. So now you'll see when others stop drinking, this person has an inability to stop drinking and to continue. And then one begins to drink when they feel good, one begins to drink when they feel bad, and one begins to drink just for the drink.
For the sake of drinking.
Absolutely. And if it continues in this person who is predisposed, then you start seeing the chronicity of the disease. You start seeing a real acute component, blackouts, the loss of control. And this loss of control is characterized by the loss of drinking, the control of drinking, the loss of the jobs, the loss of families, the loss of many, many things, even to the deterioration of health.
Well, I agree with Dr. Fatoki that it's better not to start.
That's right.
Because you can't risk engaging toxic substances and think, well, this won't affect me. I remember that as a child, sometimes older men would give youngsters a drink of something strong to show that they could tolerate it, that they could drink it, and and not frown and not be clumsy or lose their equilibrium. But they didn't intend for these young people to continue to do that. But the whole idea, of course, is to just avoid intoxicants, I would imagine, so that you don't have to do the trial and error piece.
Right.
But now that you're pointing out the problems that arise, once you do get yourself to that stage where everybody else has been able to put limits and you're not able to do that, now we're beginning to have the problem. Do most people regard themselves as addicts when they begin to lose control of their ability to stop doing whatever this substance abuse is?
The way I see it, I don't think anyone wants to lose their family, lose all their money, lose their businesses because of no one wants to go out to lose all those things, voluntarily. So once people get addicted, it's just an uncontrollable urge and a craving which overwhelms their lives even in the light of negative consequences to their behavior. I have patients who are physicians, who are nurses, and I've lost a lot of things. I have patients who are business owners and lost everything that they owned before they finally decided to seek treatment. I don't think anyone wants to
own it.
Right, or to get to that point in their lives. So that's why many times it's something that will push people to seek treatment. Either they're having problems with their family or it's an issue with the court system, before they decide to seek help. But I don't believe that people want to go out and use drugs and get to that point where, they have to sell everything they own for them to be able to keep craving or getting treatment for those drugs.
So now that we have the problem, now that we have a problem which is out of our control, and we are not admitting to the fact that we have a problem, is this an individual problem, or, as I suspect you're going to answer, this is a family problem, and is it the family who recognizes that you're addicted before the individual?
Well, sometimes, usually I will guess maybe Dr. Redmond might be able to answer that since he's a psychologist.
I think it's both.
Okay.
It's the ID, the individual patient, and then it's the family. But one of the hideous problems to this process is this whole concept of denial. which is one of the phenomena of the disease. When the person denies the fact that they are losing the control of the drinking while the drinking is getting worse. And with this denial comes many defense mechanisms. And the person began to defend against the drinking because the drinking is adding some sort of benefit. And that's what I found is a major problem. Alcohol and various kinds of mood and mind altering chemicals are reliable. If the person wants to alter their state, it will alter their state. People aren't always reliable. So now, if this person have found some sort of escape, pleasure, or artificial self-well-being, then the person will struggle and fight to guard the drugs, to guard the alcohol, irregardless of the family's report about something is going wrong.
So here we are with the state of denial and the loss of relationships and the loss of assets and all of this kind of thing. Now, how widespread is substance abuse? You said you worked in the prisons, you worked at youth centers, you are now working in a treatment program out of a hospital. Is this a small problem that affects a few families, or is this something that the community ought to be alarmed about?
It's a widespread problem. It's not just an individual problem, and I think a lot of people have the misconception that it's the street drug user who is addicted to drugs. There are a lot of people that are addicted to prescription pain medications.
Yes.
For example, I was reading some statistics that shows that even though the U.S. has about 5% of the world population, 80% of the opioid drugs that are manufactured are used in the U.S. 99% or 90% of the hydrocodone that's made in the world is consumed in the U.S. So there's a big problem with prescription drugs that a lot of people fail to recognize or are in denial over. So it's not just the heroin addict that's an addict. So it's more of a widespread problem. There are about 2 million opioid users in the United States.
2 million?
Yes, that are addicted to opioids. And you're not counting tobacco, you're not counting other drugs, you're not counting alcohol in that number.
All right. And this means that if you have 2 million individuals who are addicts, then that's 2 million families that individual belongs to.
Yes. And
various other relationships that individual has.
Yes.
So it's a widespread problem, and we have something now that is altering the relationships of people, and also because it's altering the behavior of people, is the brain being altered in the course of using these various intoxicants?
Absolutely.
Okay.
One thing we know that the neurotransmitters that the doctor was talking about earlier, they are also altered when persons begin to abuse large quantities of various kinds of mood mind altering chemicals. And that's where a lot of research is being done now to see if in fact the psychoactive drugs that affects the brain is also affecting the brains in other areas that causes a depletion of certain neurotransmitters. For example, it's many studies out there speak about cocaine. When a person uses cocaine, after the person consumes the cocaine, it reaches the pleasure center in the brain. When it reaches the pleasure center in the brain, the person's had that aha moment, I feel better. But it rapidly, within 15 to 20 seconds, they begin to lose that feeling, and they go what we call a crash. They leave from this feeling of euphoria to a feeling of dysphoria. And as a result of that, it promotes them to want to use more and more and more of that drug. So, and each one of the drugs that are being abused has a particular receptor in the brain that it attaches to which causes various kinds of reactions that people enjoy. You find some folks that want to kind of cool out. They will use things like narcotics or depressants. You have some that want to transcend their problems or transcend their immediate state, so they use some hallucinogenic drugs or some sort of cocaine, methamphetamine. And then you have those that don't want to go too far but want to alter their state some. They use the marijuana.
How do we learn to use drugs? I mean, what would tell you that if you want to alter the state of your emotions, that you should go? I can understand, because America has a number of distributing companies that distribute alcohol and advertisements for that purpose. I can understand how, because that's part of the social scene, that you just will come in contact with alcohol, you'll be offered alcohol. It's social to drink, with other people on certain occasions and all of this. But how does one get the notion that if they should use, say, cocaine or heroin, that it is going to have some benefit and bring some enjoyment? Who puts that out there?
Well, I'm not sure if someone puts it out, because if you watch, even if you look at populations from like centuries ago, they use mood-altering drugs for religious ceremonies. So I think it's something that has always been, from time immemorial. It's something that man has always done.
Okay.
But as far as for recreational purposes, some of the drugs used to be legal medications, like cocaine used to be used in cough syrup and different things like that. I know when I was in medical school, cocaine is still used in the operating room to control bleeding, especially during nose surgeries. So some of the drugs were legal. It's just that people tried them and found out that they produced a different desirable, pleasurable effect, and started to use it recreationally.
Well, I think that if we are talking about something that can alter the mental capacity of people, that we're talking about something that may be irreversible, because my information is that brain tissue is damaged. Brain tissue is irreversible, that you don't regenerate brain tissue. Is that correct?
Generally, you don't.
Okay.
But even, to go back to what Dr. Redmond was saying, there are studies that show that even after people stop using drugs, the changes that occur in the brain do not get reversed to what they were prior to the onset of the drug use. So the changes are there, and that's why I guess the scientific community is trying to look at addiction as more of a chronic medical problem. There are people who stop using drugs and then relapse many years later. So it's just something that needs ongoing treatment.
That's one of the reasons why I call this show Arrested Development, because I suspected from conversations with Jamelia Han and from other people who have some knowledge in this area that that if brain cells are disintegrating under the influence or in the context of substance abuse, that certainly that's interfering with what the organism would have become had everything remained intact and continued, with an uninterrupted development at a normal pace. And so you have cases where you can actually see that people are behaving at a stage of development that is much lower than their chronological age. Have you seen that?
Yes, which there's studies that suggest that once a person starts to use alcohol in large amounts over a long period of time, that the maturation stops. So then it's this age that a person may be 40 years old but functioning and making decisions like a 20-year-old or maybe a lesser age because that maturation has stopped.
And so here you are living with a person who, or relating to a person who is allegedly supposed to know better, but does not know better, because that person is only an older person, but not a wiser person.
Right.
That's correct.
And
right.
not fully developed. So we have this situation. I know that we have a lot of crime associated with substance abuse because it's expensive to try to maintain a drug habit. And I also know that we have a lot of incarceration associated with substance abuse and getting involved in that whole industry. And so we have more than just the problem of people having mental disorders as a result of that, medical problems as a result of that, but we also have families that are disrupted because members of the family are now in the prisons, and as you point out, they are not really getting the kind of treatment that they need in order to be able to manage these substance abuse problems. Am I repeating what you said?
Yes, you are.
Okay.
That is correct. Because at the county jails, most of them are there for short periods, but they come in and end up going back. They come into the jail, they get released, they come back doing the same thing. And then even though they know what the consequences are, and that's part of the reason I got interested in addiction, because I felt most of them needed help. I mean, don't get me wrong, there are some people that are bad and are criminals, but a lot of them are there because of some behavior that they can't stop, usually related to drugs. Either they commit a crime or they prostitute themselves trying to get money to buy the drugs. And
Can you help me make a distinction between cocaine and crack? Because I know that the penalties for using it, for distributing it, for selling it are much greater than for cocaine. So is this a different chemical? Is crack not just a derivative of cocaine, but it's something else?
it's the same compound, except I guess if you look at the economics of it, cocaine is it's like a Cadillac and a Yugo. So they are both cars. Cocaine is the drug of choice for affluent people, while crack is the drug of choice for the poor people and especially minorities. And that's where the disparity comes in, is that minorities receive a harsher sentence for using crack, which is the exact same thing as cocaine that the more affluent people use recreationally and get slapped on the wrist for.
Does it have a different effect?
It doesn't.
It does the same damage to the body, to the brain, to the relationships. The outcomes are the same.
It's the same outcome, even though I know part of what the claims are is that crack is more addicting than cocaine, but it's the same thing.
So when we find that we have drug problems in our community and our families, what are we to do? What is the family member's role? What is the addict's role? Should the addict decide that he or she no longer wants to be addicted? What are the strategies? What can be done?
There's 3 different strategies that I've experienced in the field, and one is called maturing out. And there's a lot of addicts, whether alcoholics or using various kinds of drugs, they come to a point that they just say, I'm too old for this. I can't do this anymore. And then they make a decision to stop.
And they can stop?
Yes, some. They make a decision that they stop, and this is called maturing out with no treatment.
Okay.
All right. The other one is called spontaneous remission. And this is, I've had patients that told me that they were sitting in the crack house and they had just stolen goods, sold them, made money, and purchased some cocaine, was sitting in the in the crack house, preparing to use, and they just said, I'm not going to do it no more, and walked off and left that. And there are studies that also supports that. And when you say, well, what happened? And the person just said, I just didn't want to do it anymore. Those 2 things. The third one is the family intervention. And it's not in the early 70s and the 80s, it was this confrontational means of strategizing around helping a alcoholic or drug addict by telling them, you can stop that, pull up the straps of your boots and come on, get it together. But that doesn't work as much as showing care, showing that you really care. Look, Michael, the family, and I'm speaking about family intervention at this time, where you bring different ones so it won't be a tug of war between the mom and the identified person, or the father and identified person. We bring in cousins, uncle, aunts, and maybe the person's friend, and all will then talk to the person and just share what they've observed and help the person see that there's been a major negative change in his or her life, which at some points the person will drop their guards, drop the denial, and say, okay, what do I need to do? And at this time, it opens up the way for the person to receive some sort of help, whether inpatient, outpatient, depending on the severity and the history of the problem.
And what percentage of those cases would you say you might see?
About 65%.
About 65%.
65%.
Okay, okay. So, Dr. Fatoki, where do you come in?
Well,
What is your role?
I think the first step is for the addict to recognize that they do have a problem and that they are not alone, and that they can get treatment, they can get help. With the internet, it's opened a different world where people can search things under the privacy of their home without feeling bad or without that stigma. A lot of my patients come in because without even wanting their relatives or anyone to know that they have a problem. And it's more, for them to be able to feel comfortable, for providers like myself and Dr. Redmond to educate the public more so that people can know that they can seek treatment. It's not a one size fits all. People have to find a treatment program that's suitable for them. For example, the way I have my office set up is more like a private office setting. I treat children, I treat adults of all ages in a regular family practice. So when my patients come, no one knows why they're there. But I do recognize that patients who use drugs, when they need treatment, if they call for treatment, if you don't schedule them right away, they're either going to end up using or they're going to go somewhere else. So those patients, I get them in within a few hours, if not the same day. Whenever they call, I make extra provisions to get them in, because I know when they cry for help, they really want that help right away. And if you don't take that opportunity, it might take a few more months before they cry for help again.
Or never.
Or never.
I want to bring this up because it at this point, it sounds like it's pretty much straight ahead. You somehow you develop this problem, and then you may just decide that you've done it long enough and stop, or a door might open and you might see the light and walk through the door and close it behind you, or the family might have enough and they might just confront you and cause you to have to change your ways. But then, of course, as you point out, the fourth part of it is when you get ready to change your ways, sometimes the changing your ways is not easy to do, especially without some professional help. And so I'm thinking that that this memo that I got from Jamelia Hand talking about the estimated $71 million from the Illinois Department of Human Services Alcoholism and Substance Abuse and Mental Health Divisions must have something to do with the ability of professionals such as yourselves to be able to help those who need help and who seek help, because if the budget is being cut by that amount, and if it's affecting the very sources of funding for treatment centers, I know that there are a lot of community mental health centers that either no longer exist or they are in the process of being phased out. So that if we do in fact have drug abuse problems and we don't have places where people can get treatment, then what can we expect? Can we expect an escalation of the problems, or can we expect that the problems, people will be able to just say, okay, I can't get treatment anywhere, but I'm tired of doing this, so I'll just stop? I mean, is that?
I don't think most people will just stop doing drugs.
Okay.
I think what we'll see is that there's going to be an increase in crime. There's going to be an increase in the health costs, because you do have other health problems associated with drug use. like hepatitis C, HIV, will more than likely see an increase in that.
Mhm.
The money spent on drug treatment generally is money well spent. For each addict that gets treated, you're saving about $4 to $7 in property crime, and
How much?
about $4 to $7
Okay.
for decrease in crime for each person that gets treated. When you
Okay.
factor the healthcare costs in that, you're saving about $12 per patient,
Okay.
and it's only adding about 2 cents to the health insurance cost. So compared to the benefit that comes out of getting treatment, the amount spent on drug and mental health treatment is money well spent. And I suspect that we'll see an increase in crime rate. We'll probably see more overcrowding of the prison system, because the addicts, when they want their drugs, it's an uncontrollable urge. So whatever it takes to get the money to get those drugs is what they are going to do.
Because they actually are suffering when
Yes, they
it's
are.
not just they want to feel good, but they are actually suffering, are they not, when they have these withdrawals?
And when I worked in the prisons, the only treatment or the only addiction that we treated withdrawals from, or the dependence, was alcohol. And that's because people could die from alcohol dependence. But people who came in addicted to opioids, they let them go through with the withdrawals, which might take a few days. And, they just get really sick. They can't eat. They can't function. They're vomiting all the time. They're just there. And, it's kind of inhumane, but we just watch them go through that, because a lot of the counties don't pay for those kind of drug treatments.
You use a term that's unfamiliar to my viewers, it's opioids.
But that's things like heroin, like Vicodin, Lortab, hydrocodone. Those are the opioids.
Okay.
They are narcotic drugs.
All right. So you have a private practice in which you can do treatment for addiction problems.
Yes.
And you are working in a treatment center in a hospital setting.
Absolutely.
Okay.
What we do is perform medical stabilization, which is another term for detox. And as you were stating earlier, we see very, very sick patients. And I mean, sometimes the patients are so sick that the nurse will have to begin intervening on the problem before we take all the information down. And that's basically your narcotic users, the heroin users. And this new one, this Oxycontin, we've really seen that there's a lot of problems emerging as a result of using that particular
That's a new drug on the street?
Yes.
Oh, really?
Yes.
Well, it's a prescription drug.
Yes.
It's a
one.
For
prescription
pain.
drug.
Yeah. So the
Okay.
prescription drugs are quite widespread, probably more widespread than heroin is.
Yes, that's the big one right now. And a lot of the research is talking about now these over-the-counter drugs because they're so accessible. And as a result of that, and then you have these really friendly, as I was reading in one research, that you find some physicians that are really friendly and they're really nice and they really want to help the patient, and sometimes not having the addictions background, they prescribe medication to those who are suffering, and it just compounds the problem.
Really? What kinds of medications are safe to prescribe to someone who is already having a problem with drugs? I've heard of methadone.
Yes.
Is that a one size fits all? That everybody is given methadone, and
No.
that's a
Right.
okay. What is methadone used for? What do you do with that?
Methadone is used for opioid, the narcotic treatment.
Okay.
So like Vicodin or heroin, Oxycontin, those kind of treatments.
Okay.
But methadone is it's what's called a full agonist. So it binds onto the receptors just like the drugs will. So patients can still get high on methadone. But it does change lives too. People do very well on it. Some of the setback is that for the first few months on it, they have to come to the clinic every day to get the medication. So they just can't have a take home with it. There's a newer drug which you can prescribe in the office, and that's the one I had mentioned earlier that I got certified to do.
And what is that?
It's called buprenorphine.
Okay.
Okay, that's the generic name. And the patients do very well on that. A lot of the patients I have on that are working people or professionals, people who travel a lot, so it's easier for them to get a prescription and then they take it every day, just like they would take medicine for high blood pressure and diabetes.
When you say they do very well on that, I need you to
You know,
elaborate.
it's like, I'll tell you, it's like a night and day thing. Like I see them come in real sick, and within a few days on the medication, they're a totally different person. They are a changed person. You know, their life is more normal. They're able to keep their jobs. For example, I had a patient who worked in a veterinarian clinic, and she was so worried about losing her job because she would use some of the narcotics from there and inject herself. You know, that's how she got addicted to drugs. And I had to work with her to get her the medicine over the weekend so that she wouldn't get sick at work, for her employers to know she was sick. But by the time she came back to the office a few days later, she was a different person. It's just, it's amazing. It's like a night and day thing.
Okay, I understand that a component of drug treatment is counseling. How do you get somebody who is stoned? I mean, how do you reason with somebody who is not there to reason with?
Once they start treatment, they start changing, and the counseling is a key component. Without the counseling, the medications by itself will not do too much.
So what sort of counseling, what's the direction the counseling takes? Is it thou shalt not use drugs, or, you know, that's a naughty thing to do, you know?
Redmond, you want to take that?
Yeah, there's several schools of thoughts that are the basis of some of your treatment modalities. For example, behavioral therapy. And behavioral therapy, what they believe is if you reward good behavior and give consequences for bad behavior, that it will help the person begin to make better decisions. For example, if the person is on a unit and the person is going to all of the group therapy and is managing his or her affairs well, then they will give them vouchers, and the vouchers might be for $5 that they can purchase different things. If they are not performing as expected, then there will be consequences for that behavior.
So that's counseling, and it isn't all just sitting around in a group session with the group leaders, you know, having you tell your story and then tell you what's wrong with what you just
That's
did.
one form of counseling.
That's
That's
only
one form. Okay,
Yeah, there's
well,
so
see,
many forms.
well, that's very
Because even
interesting.
there's even one called cognitive behavioral therapy, CBT, and what CBT believes is that something's going on with the person's thinking. The way the person is viewing himself, reviewing the world, and reviewing society is distorted. And as a result of this distortion, a person is having these negative thoughts, and these negative thoughts might be the source that's compelling a person to need to alter their state. So if you can get the person to start thinking more positive about himself, about the world. For example, there are some clients I have that they feel, you ask them, well, how do you feel about the world? And they say, well, the world is an unsafe place. Okay, that means something, you know. Or they might say the world is not fair. And so now, deductively, they say the world is not fair, people are not fair, and I'm not being treated fair. And as a result of that, they react to those different things.
I sometimes feel that way.
Yes. But, you know, it's the out of control feelings. It's when a person feels a certain thing and they're able to find a place to vent that feeling or to share that feeling, then they're okay if they can get some feedback and then move on. I'm talking about the person that get this sense of stuckness, when they get stuck in those ideals and then they're unmovable, and then that causes them to begin to have problems with thinking clearly.
Well, I don't want to justify substance abuse because it's destructive. I think it would undoubtedly be most destructive to the individual who is having this problem. But I do think that, you know, when you look at the condition of many of our people in the black community, you can very easily see how they would become, how they could adapt a feeling of impotence, of hopelessness, because, you know, first of all, this is a revenue-driven society. You have to have money to live in it. And then, of course, you see all of the advertisements on the billboards and on the TV and on the radio of the things that people have that make them happy. And so you need houses and cars and jewelries and flat screen TVs and 2.1 children, you know, all of these things. Or you need, you should be married, you should have family, you know, you should, you have these models that are set before you. You have these standards that are set before you, that very often you have no legitimate way of attaining those objectives. And so you might become despondent. Do you have people who may be legitimately depressed because they do have some real problems?
Oh, yes.
Oh,
There's
yes.
quite a few of those, and that's why the counseling and being able to do a proper evaluation comes in, because those disorders need to be treated along with the substance abuse. Otherwise, you won't be able to make too much of a headway with the substance abuse treatment.
So when you find that you have somebody who has very deep economic problems, for example, you can't write them a check. So what kind of counseling can you give someone who is in the throes of foreclosure or job loss, or Enron ran off with their 401k? I mean, can you imagine if that happened to you? If you thought that you had worked and you had sacrificed and saved for years and years and years, and you had some sort of margin of comfort there in case you had an emergency, and that is just wiped away. What about trauma and drug abuse?
That's
I mean,
that's one of the major problems.
Okay.
We see and the traumatization, especially in the urban areas, all the time. I mean, you find some children who, if someone began to fire a gun, that they might just look and see where it's coming from instead of running, because they've gotten conditioned to this shooting and this bottle throwing and stone throwing all the times. Most of my patients that I've worked with have some degree of either attachment issues or trauma. And
Trauma.
yeah, just
Think
big thing.
about every day when you watch the news, some child has been killed. You know, some horrible crime or some horrible event has occurred, and you read about some communities where they send in the grief counselors, and everybody comes in to soothe these people and help them to get over their emotional pain. And but then in the communities, in the black community, these things happen back to back.
That's right.
There aren't any grief counselors coming in. There are
Right.
no people who are there to see to it that you can manage this trauma and maybe, you know, transcend it eventually, if not immediately. So we have a lot of that, I think, and it would not, it ought not to make us become self-destructive, but just the same, we do have a lot of trauma that we deal with in our community, and of course we have a lot of drug use that we deal with in our community. We have a lot of social problems, don't we?
We do, and I think sometimes when people feel hopeless and helpless, it compounds that too. So one of the ways to try to sort through that is to, if we can get the counselors in, to at least let people know that there is some hope, even though everything may be hopeless, and that's where the spiritual aspect of the treatment comes in too.
Yes, yes, the spiritual component is a major component. Jamelia Hand gave me a website called turntohelp.com. Very often people don't really know where to go, because when you think about many poor people not having any kind of medical insurance, no hospitalization plan A, plan B, Medicare, whatever, they don't have the resources to go to seek help. They
Right.
don't know how to find help. For example, I know that if you are a physician and you are treating patients in your office, there must be some means of getting those patients, you know, funded.
Right.
So what kinds of funding can you accept as a private doctor?
Well, both private and government insurance, and also self-pay. For the self-pay patients, I try to discount the payment, but even the government insurance is pretty low compared to what you get from an insurance like Blue Cross or United. You get about maybe 25, 30 cents on the dollar for what the other insurances pay. So that's doing more of charity work too, than.
So that's like pro bono in your field.
Right.
Yours is like pro bono.
Yes.
So you Medicare and
Medicaid
and Medicaid,
and then the private insurance. the
private
PPO.
insurance.
Yeah.
Does the welfare has a blue card or green card?
They call it a green card.
Green card.
That's Medicaid.
Okay. Does there are so many things that so many plans don't cover.
Right.
Do they cover the kinds of treatment that you offer?
For the buprenorphine, the prescription, they do cover that. You know, when because that's a prescription, you send the bill in like a private physician office visit.
Okay.
But the methadone treatment, there is some funding through DASA, and I'm suspecting that's where a lot of the cuts are coming from.
So you are you saying that people who are now getting treatment at in methadone centers are running the risk of not having access to those? Well, what will they do?
I don't know, unless they either start having to pay or go back to crimes and to drugs. And the way I see it too, the drug dealers are not just sitting still, because every opportunity they see to increase their business, they will. So if the patients can't get treatment, then the drug dealers are probably going to try to get them more drugs.
And because they don't have any money to pay for these drugs, it means that they're going to have to find some money somewhere.
Alternative ways.
Well, that's
Right.
That's a nice way of taking it from your neighbor.
Right. I think we're going to see social chaos if this actually happens, because we have a total of 11 sites in Illinois, and all of our sites, basically 80 to 85% of our revenues comes from the green cards, from public aid, and the other 10% Medicare, 5% other commercial insurances. So if the budget is cut as they are posturing about right now, that means that 80% of our patient flow will not have entitlements to receive the treatment that they may need.
Listen, this memo says, a list of proposed budget cuts as compiled shows 43.3 half of the million, half of the state's funding for treatment services, 9 million for programs like jail diversion, domestic violence, and work release, 4.6 million reduction to grant programs and transportation, 4.3 million cuts of psychotropic medication and supportive housing, 3.7 million children's mental health partnership, children and adolescent programs. Stop right there. Stop right there. We have children who need these services.
Yes, there are not just drugs, also for mental illness,
health disorder,
yes.
bipolar, and other
Attention
kinds
deficit,
Big one.
schizophrenia.
All of these alphabets that they put on children in the school system.
Yes.
Yeah. So they're going to cut 3.7 million in mental health and children and adolescent program. I don't need to read any more. I know we're in trouble.
We're in trouble.
We're in trouble. And when you say social chaos, these are very sanitized terms that we're using. We're not saying that people who are sick and who need help are in a vulnerable position, because if these cuts are made by the governor of Illinois and the legislature, then they will have little to no chance to get the treatment that they need, and they will therefore then become the prey of the drug pusher predators in the communities where they live.
That's correct.
And of course, life cannot be pleasant for the rest of the community if that is what is going on, if that is the case.
Others become an opportunity.
So what does the community need to do? Educate itself? What does the community need to do?
Well, I guess try to develop more grassroots politics and talk to the aldermen and the commissioners and just find a way to try to avert the
Okay, so
cause.
the thing is not to let it happen, not try to lock the barn door after the horses in the next county, but to try to prevent these budget cuts and try to join with other people who are aware of what kinds of problems will ensue if these cuts are made.
That's correct.
Absolutely.
Okay. Well, I'm very, very happy to have had you to come and join me and shed some light on this problem, which is much bigger than I would ever have imagined. And of course, I'm very happy that that I was able to make the contact and you were able to take time out of your busy schedules to come to talk to us about this problem. And I thank you for coming. I want to mention your names again so people will remember that you are Adeyemi Fatoki, doctor, and your practice is the Great Heights Family Medicine. You're here courtesy of Reckitt Benckiser and Suboxone Pharmaceuticals.
Yes.
Yeah, I meant to ask you about that, and we only have a few minutes, but you might want to say something about that.
Suboxone is a trade name for buprenorphine that I mentioned earlier.
Okay.
That I prescribe from the office, and it does transform lives. Though there are two forms of it that are being sold. One is Subutex, one is Suboxone. Suboxone is Subutex or buprenorphine combined with naloxone. Naloxone is the drug that we use to reverse overdoses in drug addicts, people that overdose and come to the emergency room. Naloxone is a medication that has been around for years that we use to reverse that overdose to try to save the patient's life.
All right.
When naloxone is combined with buprenorphine, it makes it more difficult for the patients to abuse it or to try to inject it. And then also Suboxone is a partial agonist, so it binds to the receptors but not as strongly as methadone does. So it treats the craving, but it doesn't give the patient the high that they get from other drugs.
We have 1 minute. Dr. Redmond, your treatment is?
It's medical stabilization. We are the initial part of the intervention for those who are suffering with drugs. What we do is treat the symptoms that the person is bearing so that on their completion of our treatment, they can go to the next step program to receive
What's the next step?
The next step it depends on what the assessment is. The next step may be to an outpatient drug abuse program or to a MESA program that's mentally ill and substance abuse, or the person's psychiatric problem may supersede substance abuse counseling at that time, and they need to go to a psychiatric care and then receive substance abuse counseling.
All right. Well, I think we pretty much covered all the territory that we can in the hour's time, and I'm very happy that you were with me, Dr. Anthony Redmond.
Thank you.
And I meant to mention again, New Vision Medical Stabilization Service at Holy Cross Hospital. So I think we've given everybody the credits that they're due, and I'm very happy that you joined me here today. Thank you for coming.
Thanks for
Thank
having
you.
us.